of congenital ptosis management, particularly featuring a distinguished panel of international experts who hope to share their knowledge and experience. Can I ask that members do not take any screen grabs or capture any images from the presentations? The consent has been acquired for the presentation, but not for international dissemination. The panel, we're truly blessed to have Richard Allen from Houston, Texas joining us. We've got Tristan from Northampton. Raman will be joining us remotely from East Grinstead. He has a recorded talk. We've got Aoife, who is the brains behind all of this from Portsmouth. You got myself in Hull, and then Irfan Jiva in Mid Yorks. The program is self-explanatory there. We've gone through most of the housekeeping, and then in a moment I will hand over to Aoife. The questions will be run through Q&A. Chat isn't open, and so if you have pertinent questions, please pop them in the Q&A. We will struggle to answer all questions because we've got a great turnout. There may well be a meta-analysis of a few questions if there's a cross-cutting theme. Please don't be offended if your particular question has been merged with another. So without any further ado, I'd love to hand over to Aoife Norton from Portsmouth.
Okay, brilliant. Thank you so much for the introduction, Colin, and thanks to everyone joining. So this session's really inspired by you all, following on from the feedback from the last session in January. And again, we have assembled a fantastic faculty. So if you could kindly stop sharing, Ben, and then I will try and share my screen. So that's sharing okay? So I'm going to briefly touch on basically an update on current practice around congenital ptosis. And as we've heard many times before, and again this evening, ptosis is hell. Well, congenital ptosis is the absolute inferno, and management of congenital ptosis remains a great challenge in the field of pediatric oculoplastic surgery. But I'm hopeful that by the end of the evening, we'll all feel optimistic, having heard from our fantastic lineup of speakers. So it's characterized by a triad of weak or absent lid crease, decreased levator function, and lid lag, down gaze lid lag. And it really may be mild to severe with a variable degree of levator dysfunction. And the amount of levator dysfunction generally correlates directly with the amount of ptosis. The complete absence of the upper eyelid skin crease generally signifies poor levator function. An isolated congenital ptosis occurs with a prevalence of 5.9 per 100,000, usually presents at birth or manifests within the first few months of life. But it can also occur as part of the many syndromes associated. So the lid lag is a significant clinical feature to be aware of, whereby the ptotic lid is higher than the normal lid in down gaze, which can cause lag of thalamus on down gaze and the risk of corneal exposure. And the reason for this is that the normal striated muscle fibers of the levator are generally replaced by fibrous and adipose tissues. And these images show the decrease in cross-sectional diameter of the muscle fibers, rendering it stiff and poorly contractile. So it neither contracts nor relaxes normally. And the etiology of this dysfunction is not clear, and there has been debate as to whether this represents a primary muscular or a primary neurologic problem. And there's some evidence that supports a neurological explanation, namely that the failure to properly innervate the developing muscle leads to poor development. It's associated with a number of possible consequences. So obviously, if the ptotic eyelid partially or fully occludes the visual axis, then the child is at great risk of developing deprivation amblyopia, and prompt surgical corrections indicated in these cases. But even in cases where the visual axis is not fully obscured, problematic functional sequelae can ensue, including the child adopting an abnormal chin-up head posture or an isometropia, which is commonly amblyogenic. And what was originally coined simple congenital ptosis is rather the contrary. and inherently carries considerable challenges. The assessment of a young baby or child can be very challenging, and comprehensive assessment, accurate measurement of the levator function can be difficult. Surgical challenges include the lack of intraoperative feedback regarding the dynamic eyelid height and contour under GA. And when the eyelid elevators do not function, or if there's little stimulus to lift the involved eyelid, obtaining good surgical outcomes can be extremely challenging. The psychosocial impacts associated with congenital ptosis can be significant and not to be overlooked. So coordinating care with a pediatric ophthalmologist is essential in the management of these patients, with early examination and follow-up of all patients to monitor their visual development. So congenital ptosis, as we've said, not only obstructs the field of vision, but it significantly increases the risk of amblyopia from anisometropia and astigmatism. And this comprehensive meta-analysis reported the prevalence of myopia in 30%, amblyopia in 22.7, 7 times greater than that in the general population, with a high rate of astigmatism, and strabismus 4 times more common than in the general population. The cause of this increased prevalence of strabismus remains controversial. And the traditional view is that it may be secondary to an optic axis occlusion. Other hypotheses suggest intrauterine injury to the oculomotor nerve complex, or to a combined dysgenesis of the levator superior rectus complex. And studies looking at the effect of surgery on astigmatism have reported varying results. And in many cases, as in this paper, an overall increase in average astigmatism was seen after surgery, with an average increase of 0.3 diopters. And interestingly, patients older than 4 years showed an increase in average cylinder, whereas patients younger than 4 years decreased their average cylinder postoperatively. And this really underpins the importance of continued monitoring with refractive examination in the postoperative period. So in this study of children with unilateral ptosis aged between 2 and 12 years, Quarantiglione et al. From Rome found a postoperative improvement in levator function, which varied according to the age at the time of surgery. And as you can see from the graph here, there's a much greater improvement in levator function seen in the age 2 to 4 category. They found that long-term cosmetic and functional results were better, and with surgery carried out before the age of 4 years, and not only had a lower recurrence rate, but also had a reduced risk of refractive aberrations and amblyopia. And they also noted the intraoperative appearance of the levator varied according to the different age groups, with increased fatty degeneration of the muscle seen as the age of the patient increases. And as already mentioned, the psychological effects of congenital ptosis are not to be overlooked, and have been found to be associated with significant greater psychosocial mental health morbidity compared with controls. In this population study, children diagnosed with congenital ptosis were 2.5 times more likely than controls to develop a mental health illness, 2.1 times more likely to develop a psychosocial maladjustment, and patients with ptosis were found significantly more likely to have a mental health disorder or a longer duration of psychotropic medication use. And this suggests that children with ptosis may benefit from early psychosocial intervention. And this tends to become increasingly important once the child reaches school-going age. This is a great study conducted at the University of Oxford, investigating the presence of peer bias against ptosis in children aged between 3 and 6 years of age. They used a paired photograph task, which examined the effect of the appearance of ptosis on children's preferences in 2 different social situations, so toy sharing and a birthday party. And the paired photograph task showed that, sadly, with increasing age, subjects were less likely to invite children with ptosis to share a toy or attend their birthday party. 3-year-olds did not show a bias against peers with ptosis. However, 4 to 6-year-olds did choose significantly fewer children with an apparent ptosis across both social situations. So the peer bias is seen to emerge at about the age of 4 years of age, and is certainly still evident at the age of 6. So there is no widespread consensus guidelines for the exact timing of surgery, but the recommendation based on the functional and psychosocial outcomes would suggest an ideal age of between 3 and 4 years. The optimal timing, of course, needs to be combined with the correct choice of procedure in order to achieve success. And we'll delve later into this, or more into this later with other speakers. So to just understand the current landscape, we recently distributed a survey on the trends in congenital ptosis management, and thank you to many of you for completing this. So there's very good global representation in the responses, and the majority are performing surgery on children between the age of 4 and 6 years or younger, which is in line with the recommendations based on visual and psychosocial benefit. For ptosis with good levator function, the majority are undertaking anterior approach levator advancement, with a small and similar proportion performing either anterior posterior white line advancement or Muller's muscle conjunctival resection. For ptosis with poor levator function of less than 4 millimeters, frontalis suspension is the most common surgery performed, accounting for nearly 70%. And frontalis flaps are used in 23.3% of the respondents. And looking at this geographically, there wasn't a huge variation across most continents, with a reasonably similar split between frontalis suspension and flaps, apart from South America, which you can see frontalis flaps appeared more popular. And in Africa, there were no respondents performing frontalis flaps. However, the number of respondents from each of these two continents was low. So it's very difficult to directly compare each of these surgical options, given there are so many variables. But this meta-analysis reviewed 14 ORCTs and essentially reported the following conclusions. Compared with levator plication, frontalis sling significantly increased the MRD1. The Fox pentagon was significantly better than the double triangle at improving the degree of lag of thalamus, and I'm sure Irfan will go into detail on these techniques later. Open pattern provided statistically better cosmetic outcomes than the closed frontalis sling. Absorbable sutures significantly increased the MRD1 compared to non-absorbable sutures in cases of levator plication. And silicone slings were significantly increased the palpebral fissure height compared to those performed with Gore-Tex. Autogenous fascia lata provided statistically better aesthetic outcomes for lid height, symmetry, and contour. So basically, there's very heterogeneous messaging there. And in essence, different surgical methods and materials appear to affect different aspects of the congenital ptosis treatment outcome. So the majority of our respondents are using the traditional cutoff of less than 4 millimeters for choosing a frontalis-based approach, with some having a lower threshold, such as 5, 6, 7, and even 8 millimeters. And it will be great to hear from the panelists later on their preferences. A number of materials are being used as a suspension to sling the frontalis to the eyelid, and the decidedly preferred option among respondents was silicone, accounting for 54.1%, and approximately 15% are using autogenous fascia lata. So each of the materials have their own indications, advantages and disadvantages. A silicone sling is usefully elastic, can be adjusted both intraoperatively and postoperatively. But one of the main drawbacks tends to be the rate of late ptosis recurrence after surgery, and that can relate to positional migration, weakened tensile strength, and micromorphological changes. Reports of recurrence rates for silicone rods can be as high as 30% at 3 years after surgery. Autogenous fascia lata has been considered to result in much lower recurrence rate and lower complication rates, and considered by many as the gold standard material of choice, but is not suitable for children under the age of 3, generally speaking. So Supermid, on the other hand, has been associated with high rate of recurrence and is not thought to be a reliable permanent solution. Scanning electromicrographs of Supermid used in ptosis cases that recurred showed that the material undergoes a morphological degradation by hydrolysis, supporting its use as a temporary measure, generally reserved for infants who need their ptosis addressed quickly. but who will later undergo a more permanent sling. The Merceline mesh ptosis sling had historic popularity, is still used by a small proportion of respondents, as is Gore-Tex. And looking at why the recurrence rates appear so much lower with fascia lata, histologically, it showed less inflammatory reaction and better incorporation with surrounding structures than the silicone band. And these slides show the fascia lata implant being replaced and completely by collagen fibers and merging into the adjacent vascularized fibrous tissue at 8 weeks after surgery. In contrast, on the right, and this representation of the silicone band, which showed marked inflammatory reaction initially and did not incorporate with surrounding tissue in any of the samples, where an empty space was surrounded by dense collagenous fibrous bands. So trying to evaluate the comparative effectiveness and safety of various materials is rather difficult. There's one Cochrane review identifying 3 randomized trials that had compared 4 different materials, 2 materials in each trial, including Gore-Tex, Ethibond, Merceline, and autogenous fascia lata. But the conclusion really was that there was inadequate data to facilitate identifying the optimal material, and that future randomized trials should be more rigorously designed. An important goal of ptosis surgery is achieving an acceptable lid height, contour, symmetry, and all of these can be challenging, which a large proportion of respondents reported experiencing. And one of the concerns with unilateral sling is the asymmetry between the lids, especially in down gaze. And another concern is whether patients will have spontaneous unilateral frontalis action to utilize the sling. And this may not be a problem for non-amblyopic patients, but patients who are amblyopic on the operative side or have fixation preference may have variable success with the unilateral sling. And for this reason, some surgeons routinely offer bilateral surgery in the cases of unilateral ptosis to address this. And in our survey, this equated to 11.6% of respondents, with an additional 18.6% sometimes performing this. And this should open up some interesting discussions later about shared experience in this regard. So before I finish, I'd like to share this teaching from Anderson quite some time ago on the septal pulley theory, and perhaps we can hear others' views on it later. But basically, traditional frontalis suspension techniques, where the sling is placed superficially, can lead to cosmetic issues due to the non-physiologic elevation force of the upper eyelid. And these include tenting of the skin, loss of the skin crease, and the eyelid, as you can see here, being pulled away from the eye, especially in patients with more prominent brows or deep-set eyes. And this occurs because the traditional approach alters this natural supra-posterior lifting force of the levator into a more of a superior vector. And Anderson et al. Suggested a more physiologic approach would be anchoring the sling behind the arcus marginalis of the orbital septum, utilizing the septum as a pulley and redirecting the lifting force posteriorly, and this more closely mimicking the natural lifting vector of the levator muscle, which should lead to better cosmetic outcomes and improved lid crease formation. I'm going to finish up with this last question, which was, what is the preferred time for revision surgery if a suboptimal outcome is achieved? And there's a great range in the answer to this question. In reality, it will likely depend on each clinical scenario. And again, looking forward to interesting discussions later about this. So thank you all for your attention. We will now move on to our next speaker, Irfan Jifa. So Irfan will talk to us about frontalis suspension, and I'm looking forward to your talk, Irfan.
Thank you very much. Right. Thank you, Aoife, for that wonderful talk. I quite like that slide on 11% referring to do bilateral surgery, and I have some very interesting experience in that. So yeah, looking forward to that. And good evening to all the colleagues. Delighted to be part of this bopss webinar series on the art of ptosis surgery. This talk is a practical overview drawn from my NHS international and private experience, focusing on the congenital ptosis management. Frontalis suspension is often the procedure of choice for severe congenital ptosis, where levator function is poor or absent, defined as less than 4 millimeters. While it may appear to be deceptively straightforward, outcomes are closely tied to nuances, both in technique and patient selection. By the end of this talk, I aim to provide practical insights into selecting the right patients, choosing the appropriate material, optimizing your surgical technique, managing common complications, and perhaps most importantly, cosmetic rehabilitation post-surgery. Patient selection is a cornerstone of every successful surgery, and frontalis suspension is no exception. The ideal candidate is a patient with poor or absent levator function. Robust frontalis activity is essential, as the success of this approach hinges on frontalis compensation. It is equally important to confirm a good Bell's phenomena. Not checking for Bell's phenomena, corneal sensation, or dry eyes falls below the standard of care expected from anyone performing this surgery. Preoperative evaluation should include amblyopia assessment, especially in unilateral cases or where ptosis obstructs the visual axis. Parental expectation must be managed, particularly regarding the likelihood of undercorrection, the need for sling adjustment or revision, longevity, and post-op cosmetic rehab. So let us delve deeper into the rationale behind sling material selection. While fascia lata is considered the gold standard, its utility is sometimes limited. The traditional teaching is to use it in children over 3 years of age. However, I have personally been able to get fascia lata in children as young as 18 months of age, because you don't need a lot of it. There are some very good synthetic options. Silicone rods are often the material of choice for young children. Their elasticity allows a more natural lead excursion with blinking and forehead movement. They're easy to insert, and as we heard earlier, to adjust postoperatively and remove if necessary. This makes them suitable in a growing child where surgical revision is more likely. When choosing a material, age is an obvious factor. But other nuances also matters, like the strength of the frontalis, the degree of ptosis, symmetry with the other eye, likelihood of needing future revision, and even your own familiarity with the handling characteristics of the material. Material selection is rarely a one-size-fits-all decision. While the literature offers robust comparisons, experience teaches us the subtleties. How each material behaves in real tissue, how children heal, how parents react to revision needs or visible outcomes. Now, fascia lata remains my first choice in children where they are suitable. Its integration is unmatched, and its durability offers reassurances in cases where long-term stability is crucial. Excuse me. Donor side morbidity has been raised as a concern, but in my experience, this is uncommon when performed with appropriate instrumentation and technique. This is a paper that I would highly recommend. It talks about harvesting fascia lata in a very simple step-by-step manner without using any fancy instrument. This is my to-go technique, and I would highly recommend it. Silicone rods in my hands are quite effective, especially when asymmetry exists between eyelid height and brow action, allowing tailored tensioning. I like silicone rods not only for their elasticity and adjustability, but because they give me a margin of safety. For those who may know me, for many years, my work took me to different countries. And during my international travels, I once worked in a country that was recovering from war. There were limited resources, and I used 2O and 3O proline, which worked well. In another part of the world that was devastated by natural disaster and had limited resources, there was somebody who had donated many DCR tubes, but there were no DCR punches. So we used the tubes, and it worked really well. So on reflection, I now believe that material choice in frontalis suspension is both evidence-informed and experience-shaped. One must balance tissue behavior, patient age, surgical goals, and the predictability of each material in one's own hand. There are various techniques of frontalis suspension. This is my to-go technique, the Fox Pentagon technique. It involves 5 incisions forming a pentagon-shaped sling. I've had very good outcomes with that. There are other techniques like Crawford double triangle technique, modified Crawford technique, and they're all good techniques. And it just depends on what you've been trained with and what you're comfortable with. Now, the success of frontalis suspension begins well before the first incision. Precise preoperative planning is fundamental. Perform marking with the patient upright. Gravity changes lid-brow relationships considerably. I always align my markings with the mid-pupillary line and supra-brow reference points. Assessing frontalis function is particularly important in congenital ptosis. In younger children, I use verbal cues, look surprised or playful expression, to gauge muscle recruitment. It's not just about presence, but symmetry and sustainability of contraction as well. Bell's phenomenon is an essential safety parameter. A weak Bell's raises the threshold for aggressive elevation, so aim for slight undercorrection to protect the cornea. I also apply gentle traction intraoperatively to mimic blink closure strength and predict postoperative leg ophthalmos. I close my wound with 6O Vicryl in low tension. There is teaching that one should not use Vicryl in patients with Fitzpatrick skin type 4 and 6 because of pigmentary and keloid issues. That's not been my experience, and I'm quite comfortable using Vicryl. Discuss material choice with parents early, particularly if you plan to use silicone, because I've found that informed parents are more accepting of staged procedures, especially when they understand the trade-offs between revision potential and long-term durability. The steps of surgery are all available in texts and online. In my experience, during surgery, it's the small decisions that makes a difference. For tunnel creation, I strongly recommend blunt dissector like Wright's needle and using instruments to protect the globe. A superficial tunnel just deep to the orbicularis helps maintain a natural lid contour and reduces the risk of retraction or exposure. When adjusting tension, I routinely aim for 1 to 2 millimeters of overcorrection. This accounts for material relaxation, especially important with silicone, and soft tissue settling postoperatively. Fixation to periosteum, particularly in older children or those with strong frontalis activity, reduces the risk of sling slippage. With silicone rods, I favor using a silicone sleeve lock or a double pass at the brow apex to maintain tension and reduce migration. If child has poor Bell's, I dial back the correction to avoid exposure keratopathy. It's better to revise upwards and to manage corneal ulceration in a young child. Once surgery is complete, the real challenge often lies in ensuring a safe and stable postoperative course. First and foremost, corneal protection is non-negotiable. I start all children on frequent non-preserved artificial teardrops with ointment, and I usually prescribe it for 3 months. In patients with poor bells, particularly bilateral cases, I consider moisture goggles in adults and temporary lid taping at night. It's important to monitor closely for signs of exposure keratopathy, especially in the first 72 hours. I advise parents to report any excessive light sensitivity, discharge, redness. I prescribe topical antibiotics post-op. Lid height changes are expected in the early post-operative phase. It's critical to counsel families that symmetry may not be immediate. I schedule reviews at 1 week, 1 month, 3 months, and 6 months. If revision is needed, I prefer to wait unless the child is at risk of corneal damage. With silicone adjustment, if it's an adult, it can be done under local anesthesia as well. So why do I choose frontalis over levator? Is because levator in severe congenital ptosis is usually fibrofatty. It does not contract well. It does not relax well. And therefore we have lid lag on down gaze. Frontalis is a long muscle. It's a healthy muscle. It contracts well. It relaxes well, and therefore it has good amplitude. However, its connection with the lid is elastic and weak. And what we're aiming to do is create an inelastic sling into an elastic connection. So after surgery, this is what we'd like to see. But sometimes this is what we get. In order to move from this position to that position, we need to think about post-surgery cosmetic rehabilitation. So what we need are synchronization with the levator of the other eye, and to be able to keep the operated eye open and equal to the other eye, even when the frontalis is not working. To achieve synchronization, we need a strong frontalis. This helps the frontalis to improve its amplitude by relaxing the connective tissues. This also helps with better closure during sleep. So the instructions that I give to my patients is I ask them to force close their eyes, open them wide, and then relax. I ask them to do this 10 times, 5 times a day, and do it for 3 months. And to achieve a conditioned reflex where the operated eye is open and equal to the other eye, even when the frontalis is not working, I normally ask help from family or friend. I ask them to give patients a target at eye level. Then I ask them to depress the chin and then slowly elevate the chin until both the eyelids appear to be at equal height. I asked them to perform this daily for 21 days, and after that in front of mirror for 3 months. And that's where, just with conditioned reflex, we're able to go from this look to that look. Preoperatively, patient is operated, and post-op, after the adjustments, looks reasonably symmetrical. Pre-op, post-op, with the adjustment, looks reasonably symmetrical. So, in summary, preoperatively evaluate well, communicate well. The material choice must align with patient's age and risk profile. Do upright marking. Intraoperatively overcorrect, that helps with late undercorrection. Close post-op follow-up is essential. Master these nuances because that yields good long-term success. So where are we right now? Frontalis sling is a gold standard. It's a time-tested. It's been there for 100 years and works really well. However, I see frontalis sling as extracapsular cataract extraction, works really well. But now we have phacoemulsification, and about 7 to 8 years ago, I moved to frontalis flap, and I have not looked back. And I'm quite looking forward to Richard's talk. Um, um, it's I think the future of congenital ptosis. I'm going to end here, but take this as an opportunity just to thank few people who are in the audience right now, who've played an important role during my training and after my training as well. Very briefly, quickly starting with Colin Wise, who was my first trainer in 2007. Thanks, Colin. And Bernie Chang, who's helped me to learn and love oculoplastics. Manoj Parulekar, who helped me understand the beauty of eyelid surgery in children. Yasser Khan, he's an ophthalmologist from Canada. He used to fly over to help me deal with really complex cases, and somebody who introduced me to frontalis flap. Bobby Korn, Guy Massry, I'm highly indebted to them. And most importantly, without a good team, we can't really perform well. So thank you very much.
Thanks very much, Ev, and that was brilliant. A really comprehensive talk about frontalis suspension. We've got we're just questions are just appearing, which is great news. I was going to ask you about your surgical approach to the pretarsal areas. So do you do pockets, or some of them seem to be pockets, some of them seem to be sort of lid crease incision and possible fixation. What do you do?
I've done both, but I've come to like pockets more now.
Brilliant, thank you. So we've got first question is, can you please explain how you adjust after having the sling done?
So if we're using the silicone rods, for instance, so this is a very, very, very good question, actually. So we measured that you need about 8 millimeters of frontalis height to get a 3 millimeter lid height. So if there was an undercorrection of, say, 1 millimeter, I would actually try and tighten the sling by about 3 to 4 millimeters to get that additional 1 millimeter height. It's a bit of an art as well as science, but using the strategy of plication tends to help in tightening your sling.
Okay, thank you. And we've got a question now from Ken Chow. If revision for fasciolata sling is required, when is the ideal time to do so, especially in light of the increased incorporation of fasciolata material in situ?
Try frontalis flap. So I'm sorry, the question was, when is it a good time, right?
Yeah, to revise the fasciolata.
After 3 months.
3 months. Okay, that's a definitive answer. That's brilliant. No more questions for you, Ev, and thanks again for a lovely talk and the name check. That's very nice of you. I'm going to head to introduce Richard Allen, a man who actually needs no introduction. It was interesting in his biography that he's professor at the Department of Ophthalmology at Baylor, but also went to Duke. So you must have had a difficult time with March Madness. Baylor played Duke at basketball last week, and it must have been a tough time for you.
No, it's not a tough time. You always choose Duke if you went to Duke, actually.
Tar Heels always win. But okay, well, that's brilliant. Listen, I'll hand over to Richard, who's kindly given his time today.
All right. No, it's really a pleasure to be here. And I truly appreciate the invitation to come and talk about congenital ptosis and give my thoughts on how I approach this now, and in particular, how I've sort of adopted the frontalis flap. So I'll talk a little bit about frontalis sling as well. But at this point, I truly perform frontalis flap only for children. I haven't put silicone in now for about, 6 years. I have no financial disclosures, and first and foremost, I'm going to make the assumption that a frontalis suspension procedure is needed for the patient, either unilateral or bilateral. So we're not going to discuss the decision to perform frontalis suspension versus levator-based surgery, or the advantages of a unilateral or bilateral procedure in unilateral ptosis. I am going to discuss the different types of frontalis suspension. There'll be a little bit of overlap with the previous talk, the advantages and disadvantages of each of the types of frontalis suspension procedures, why I still perform silicone frontalis slings in adults with progressive myogenic ptosis, and also why I now perform frontalis flaps for kids. And then we'll go over the steps with regards to how to perform a frontalis flap. So hopefully at the end of this procedure, you will have been convinced to start doing frontalis flaps and also know how to do frontalis flaps. So when we talk about frontalis suspension techniques, really we split this up into either frontalis sling or frontalis flap. And, materials used for frontalis sling, as we've heard, silicone suture, Gore-Tex, fascia, which can either be autologous and sometimes donor. Frontalis sling using synthetic materials, in my mind, they're all about the same, and I think they all eventually fail. And you will have that rare patient that has a durable result, and you'll even have that rare patient that maintains a result after removal of an infected or an exposed sling. There is a risk of infection or exposure or granuloma formation, depending upon what you think is happening. I think there is an argument for a quick suture sling for a very young patient. And, it is nice in that these slings have an ease of adjustment. With regards to fascia, you can adjust these, and I think it's difficult to adjust these through the forehead. If I'm going to adjust fascia, I'll go through the eyelid, find the sling and actually plicate it. With regards to donor fascia, again, I'm not a big fan of this. There is a risk of transmissible disease, and usually if I'm ever going to consider donor, it's going to be in someone previously, before I was doing flaps, that had an infected or exposed silicone sling. And truly, to me, autologous is still probably the gold standard. When do I use synthetic materials, though? Progressive myogenic ptosis in adults, so that's going to be CPEO, OPMD, or myotonic dystrophy. And I do prefer silicone in these patients. It's elastic, it's easy to adjust, but I do tell them that I'm probably going to have to replace it in about 15 to 20 years. Usually most of these patients are older though, so at most they're going to have one replacement. I think it's important in these patients with progressive. We're going to take a little bit of a diversion with regards to talking about progressive myogenic ptosis here, because basically it's my experience with progressive myogenic ptosis that really has led me to have some very strong opinions with regards to how to do not just frontalis slings, but also frontalis flaps. So forgive my little diversion into talking about adults here. But when you address a patient with progressive myogenic ptosis, you really should not rely on levator function. You need to think about levator health in these patients and progressive disease, because levator function is just purely one of many things we have to evaluate the levator health. So in my mind, levator function is one, but also amount of ptosis, especially in congenital ptosis. You should think twice before you try to give a patient with 3 millimeters of ptosis good levator function. And, lid crease, strength of the lid crease. And then, actually a lot of what I do now is that I look at the muscle. I know that this is somewhat heresy in the sense that if you read Carl Beard's ptosis book, he says that this is not something that should be considered, but this is what I consider now in congenital ptosis when I'm trying to choose levator-based surgery versus frontalis suspension surgery, is that there's all these other things, levator function, lid crease, as well as amount of ptosis. But in the end, I make an intraoperative decision when I look at the muscle, because in my previous experience, I would see these muscles that were full of fat. And then when I'd consented the parents to do a levator resection, and I knew that that was going to fail. So now I look at the muscle. We can talk about that later. But levator function is really a description of distance. Doesn't tell you anything about the movement. And this concept of levator function not accurately affecting or reflecting levator health is not a new one. Bart Free used to talk about this. Jeff Nerad also talks a lot about it. But to go way back and sort of tell you my story with regards to how I think about frontalis suspension surgery, back in 2002, I was actually doing general ophthalmology in the state of New Mexico. So this is a state in the United States, and it has the second largest population with OPMD and these old Hispanic families that migrated there 400 years ago. And when I got there as a general ophthalmologist, I was doing ptosis surgery, and my plan was just to follow Beard's guidelines, which are basically based on the amount of ptosis and the levator function. And so if you would do that, you would potentially do levator resections on patients or levator advancements on patients if they had a little bit of ptosis and pretty good levator function. And then you would reserve frontalis suspension for those patients that had poor levator function and a lot of ptosis. So I looked at these patients when I was there, and of the 83 patients, you just sort of see this slow progression to having frontalis suspension surgery done. And this sort of led to my ASOPers thesis way back in 2009, and basically just looking and characterizing this population of patients. And, we saw that there was recurrence of ptosis, 93% after blepharoplasty, which, isn't surprising, but there is this really bad paper in the literature that was published back in about 2000 in ophthalmology, in which you would do a aggressive blepharoplasty and do sort of what skin sling, and people sort of started following it. And I say it was a bad paper just because it was based on about 6 patients, with some of them having only 6 weeks of follow-up. So, it's a paper that shouldn't be in the literature, basically. But recurrent ptosis, 93% after blepharoplasty, 47% after levator advancement, and then only 8% after sling. So, the conclusions of this was that maybe we should be more liberal with frontalis sling and consider doing them primarily regardless of levator function. And that did not get past the reviewers. And so sort of had to temper my recommendations. But realistically, in my practice, I was doing primary slings in these patients regardless of levator function, because I knew that the health of that levator muscle was not good. So even if they had 15 millimeters of levator function, you would watch that lid move, and it was very slow. And, especially those patients that have like 10 millimeters of levator function, I mean, you'd say, yeah, they by definition, they have good levator function, but realistically, that muscle is pretty worthless, and it's just going to get more worthless. So, this led to my second paper, where we just sort of looked at primary bilateral silicone frontalis suspension in those patients with good levator function. And we, out of the 150 patients we had with OPMD, 31 had good levator function, no previous eyelid surgery, bilateral silicone sling, and they did well. And so, the conclusion of this was to do primary silicone frontalis suspension on patients with OPMD and probably myotonic as well as CPEO. It's a progressive disease, and levator function is not an accurate measurement of levator strength. But, one of the viewers, said, I still do a levator advancement in these patients because it gives me a better cosmetic result. And that, to me, just seemed ridiculous, because when we think about cosmetic result and frontalis suspension, what is that based on? Well, it's lid height, obviously, it's lid contour, but it's also lid crease. And so, we've talked about height and contour, but what determines lid crease in these patients that have undergone frontalis suspension? When we think about lid crease, and it's an extension due to an extension of the aponeurosis to the dermis, and then you have to have a fold of skin and potentially pre-aponeurotic fat over the crease. So it's not just a crease, but it's also a fold, and you need to have that fold. And this is especially important when we talk about kids later. So, the third paper we did was just factors affecting eyelid crease formation before and after silicone frontalis suspension in these patients. We had 63 patients where we had photographs. We sort of graded them with regards to a distinct crease, a barely distinguishable crease, and then no crease at all. Those were just representative photos that we used for the graders. And the question is, what correlates with the formation of a lid crease? So age, gender, MRD, palpebral fissure, levator function, preoperative lid crease, and intraoperative maneuvers was really what we were looking at. And the only thing, basically what correlated was that you had to conserve skin excision. You didn't want to do an aggressive blepharoplasty. You had to conserve fat, and then you needed to incorporate the levator aponeurosis into the skin closure. And this sort of led to what I would call my 5 principles of frontalis suspension. And this is applicable, as we will see, to frontalis flap surgery as well. First, you need skin conservation as well as fat conservation. I do not cut away any skin in kids. I do not cut away any fat in kids, as well as but in adults, I might take off a little bit of skin if they have a lot. Tarsal fixation of the sling, retroseptal placement of the sling, as Aoife talked about earlier, then incorporation of the aponeurosis into the closure. And so, you can get a good cosmetic result. I would say that that is a good cosmetic result after a frontalis suspension procedure. And so, we thought that a sling is more effective, it's safe, and it can give us a good cosmetic result. I think, the other advantages is that if you do it primarily, you're doing one surgery through the eyelid. I think this is something that we really need to pay attention to with regards to doing multiple eyelid surgeries. Every time we do that, we are causing scar, we are causing orbicularis weakness, and so we're going to cause problems. The nice thing about silicone in adults, it's elastic and it's adjustable, so no repeat eyelid incisions causing problems. And like I said, the disadvantages of levator-based surgery in these patients is that you're tightening a muscle that's progressively getting weaker, worsening leg ophthalmos. You're going to require additional surgery. Basically, I do not like tarsal resection at all in patients with myogenic ptosis, if you believe, or if you as we had talked about, congenital ptosis could also be considered to be a congenital cranial disinnervation disorder, meaning bad innervation of the muscle. And then, the big one is like blepharoplasty. I've probably tried to beat this one out of the literature, lag ophthalmos, and by definition, you are obliterating the lid crease in these patients where you're doing sort of a skin sling. So I don't think anybody is talking about that today, fortunately. But if you don't have a fold, you're not going to have a crease, and sort of by definition, you're going to have a poor cosmetic result. I love this photograph. These guys are twins. And so the guy on the right has had his surgery with OPMD, and the guy on the left is about to have his surgery. So let's talk about kids. So what about kids? Well, you can get a great result with a silicone sling. This is a young kid, obviously before and after silicone sling surgery. And, here he is a week after surgery, looks great. Okay, so again, in these kids, I'm using these 5 principles. Don't cut away skin, don't cut away fat, tarsal fixation of the sling, retroseptal placement of the sling, incorporation of the aponeurosis into the closure. But I think at this point, I even go further with regards to my frontalis slings, with regards to how I place them to get a posterior vector to the pull of the eyelid rather than a vertical vector, which is what you get if you don't place the sling either retroseptal, but now I place it retrolevator almost all the time. So this is just congenital, a kid with congenital ptosis. This is before I was doing frontalis flaps. We're going to do a silicone sling. I'm disinserting the levator from the anterior surface of the tarsus. I'm going to dissect between the levator and the underlying Mueller's muscle here. I do this on all of my slings. I do this on all of my flaps. I am freeing that levator up because that levator is not strong enough to necessarily lift the lid, but it's going to be strong enough to pull a crease. I attach my silicone sling, and now I'm placing this sling actually under the levator as well as retroseptal. So this gives me a really good posterior pull. I do that on both sides. And in addition, the levator is covering the sling. So I have not just the skin and orbicularis covering the sling, I also have the levator. I excise a little bit of levator, I excise more depending upon how much ptosis there is. And then I'm going to close this by incorporating the levator aponeurosis into the closure. And this gives me a good result. I think that, the beauty of this is that I'm getting a nice posterior pull. I get no eye pop. And then here they are at the end of the surgery. And then I also get a good crease. And so here's a patient. This is actually a patient that had fascia done before and after frontalis suspension. I mean, I would say that that's a good result. She has the expected lag ophthalmos, but not a big deal. And so, as I said, you can even go further than retro-levator. You can go retro-Whitnall's, which is what I'm doing here. And so, again, disinserting the levator from the anterior surface of the tarsus, dissecting between the levator and the underlying Mueller's muscle. I fixate the sling always. I think fixation of the sling is very important. And then this sling is actually going to be placed beneath not just the levator, but even Whitnall's ligament there. So I am getting this posterior vector for the eyelid movement, which is very important in patients undergoing frontalis suspension, be that frontalis sling or frontalis flap, okay? This video gave me trouble before when I tried to advance it. I'm hoping it's not going to. Oh, there we go. Okay. So, with regards to the other issue with slings, foreign bodies, we have infection risk, but we do have some ease of adjustment. Fascia, little if any infection risk. Sometimes the leg incision, then adjustment can be somewhat more difficult with fascia. We actually looked at our infections or extrusions or granuloma formations. I think sort of by definition, they can almost be lumped together. But, we looked at our patients that underwent this. This is about 193 eyelids that underwent frontalis sling surgery and tried to figure out if there's anything that was affecting infection or exposure or granuloma formation. The only thing that we saw that helped was if you gave intraoperative antibiotics. So for any of my silicone slings, I always give intraoperative antibiotics. Soaking the sling in antibiotic solution doesn't help. Postoperative antibiotics doesn't help. Prior antibiotic or prior hospitalization or even age or gender did not have any difference. So we're going to talk a little bit about frontalis flap. I know that this is the purpose of the talk, but why would you consider frontalis flap surgery? Well, it obviates material issues, so we're not going to worry about infection. We're not going to worry about availability. You're doing one incision. You're not placing any incisions above the brow. There's no donor site incision, such as if you're harvesting fascia. And, potentially the question is whether there's any age limit on this surgery. And, to be quite truthful, I was not an early adopter of the surgery. I had good results with frontalis suspension, and I had questions about the durability of the surgery, but also I was worried about eyelid crease formation and also eye pop. As I said earlier, if you're going to do frontalis suspension, it's not just height, it's not just contour, but it's also lid crease. And I was like, okay, how are you going to get a good lid crease in these patients? Well, again, as I had discussed with regards to frontalis suspension, it all has to do with not ignoring that weak levator. Traditionally, we bypass that in frontalis suspension surgery, but we need to incorporate it. And so, why do we incorporate it? Well, to provide a posterior vector of pull and also incorporated it into the lid crease incision closure. Like I said, it may not be strong enough to necessarily lift the lid, but I think it's strong enough to pull a crease. And so how do I apply these principles frontalis flap surgery? We published this back in Eye in 2023. So, I'm making a lid crease incision. I'm dissecting through the orbital septum. I'm dissecting the preoperative fat from the underlying levator, aponeurosis, and then dissecting to the superior orbital rim, and I'm dissecting posteriorly. Then I dissect anteriorly. I have my frontalis flap here. I'm then going to pay attention to the levator muscle. I'm going to disinsert it just like I did before. This is a 5/0 nylon. I like 5/0 nylon because it's double armed and it comes on a spatula needle. It goes through the levator muscle as far as I can go, and then it goes through the flap. Okay, so I am advancing not just the frontalis muscle, but I'm also advancing the levator muscle. So I'm doing a combination procedure in these patients. Get it to the height that I want, and we'll talk about that. And then, I'm going to close the incision by taking off a little bit of the levator, and then I'm going to incorporate that into my closure so that I get a good crease. crease is so important in kids, not just cosmetically, but you'll see those kids that have had frontalis suspension procedures previously and now they have lash ptosis. I mean, basically, to me, that is due to what I call anterior lamellar slide, where you just get this descent of the anterior lamella over the posterior lamella because there's nothing trying to pull that anterior lamella up. So here's patient before surgery, and then here she is at the end of her surgery. I want that eyelid up at least to the limbus on her, okay? Especially for unilateral cases. You know, at this point, I have not overcorrected a unilateral frontalis flap. I have overcorrected bilateral, okay? So I'm a little more conservative with regards to unilateral. I'm pretty aggressive with regards to bilateral because I will take overcorrection over undercorrection any day, in the sense that if I undercorrect a patient, I know that I'm going to have to do surgery again in order to get them high. But with overcorrection, I believe that I can bring them down with massage often. So conservative management. So here she is at the end. But, you know, just a few examples before and after frontalis flap surgery, bilateral here, unilateral. I love this picture because if you look at her right eye preoperatively, she has an esotropia. She's fixating with her left eye after her frontalis flap surgery. She's now switched fixation and she now prefers her right eye over her left eye. Another patient bilateral, another patient bilateral, another patient bilateral. And then this is just a recent one. And you'll see on he's about 2 weeks out, but you can see how his brow has relaxed. And I think it's really important to see that. And I love to see brow elevation, obviously, before I do a frontalis suspension technique, because that sort of tells me that, okay, not only are they trying to see from that eye, so there's fewer amblyopia issues, but also they're probably going to use their flap. So just again, going through the steps of the surgery: lid crease incision, down to the septum, open the septum, dissect the preoperative fat from the underlying levator muscle. I usually look at that levator muscle to see if I can use it, because sometimes I'll have patients where I've scheduled them for a frontalis suspension, then I look at the muscle, I'm like, this is pretty good muscle, I think I can use this, and I'll do a levator section. Then we're going to switch our dissection to the superior orbital rim. I'm going to dissect posteriorly along the periosteum. Some people believe that you don't need this posterior dissection. I'm then going to switch my dissection, and it's really a subcutaneous dissection between the subcutaneous fat and the frontalis muscles. Sometimes you see, you know, really healthy frontalis fibers, sometimes you don't, but realistically, the tissue that's there is going to be attached to the frontalis. And I usually pull on it to show that it's actually moving the forehead. I like to see eyebrow follicles, you know, usually on the more anterior layer, because that tells me that, okay, that's as superficial as I want to go, and everything posterior to that is going to be frontalis or something attached to it. And then we have our flap. I'm then going to disinsert the levator from the anterior surface of the tarsus, and I'm going to dissect as far up as I can on the levator, because I already know that I can't do a levator advancement, but I'm going to try to resect as much as I can to at least get what I can get from the levator in these patients and provide a posterior pull, and then also use the levator to create a lid crease. I then place, this is a 5/0 nylon partial thickness through the anterior surface of the tarsus. Each arm then goes through the levator as high as I can go. Each arm then will go through the frontalis flap. I then usually will put a temporary tie in. If it's a bilateral procedure, I'm probably going to put them at about the limbus. If it's unilateral, I'm probably going to try to get them higher than the limbus, to be quite truthful. And then going to excise some of the levator, aponeurosis. The more, the better, in the sense that if I can excise more and then engage the levator into the closure, that's going to give me a stronger lid crease. I want lash eversion at the end of the surgery. And then we close this with your suture of choice. And so, you know, last slides here, basically before 2019, if a pediatric patient needed a frontalis suspension procedure, if they're under the age of 3, I would place silicone with the expectation that the silicone would need to be replaced with autogenous fascia. If they're over the age of 3 or so, I would harvest fascia from the patient for a frontalis sling. After 2019, basically, if they need frontalis suspension, I perform a frontalis flap. I truly have not placed any silicone in kids since that time. I still will place some autogenous fascia slings if the patients request it, and often that's in a family that has a history of congenital ptosis, and they've had good results with frontalis with a fascia lata before. In my mind, I really believe that the result that I get with fascia lata and a frontalis flap are very similar. I think it's the same thing. Basically with a sling, we are just placing a link between the frontalis muscle and the tarsus. And, if you place that with a stiff material like fascia, which is going to survive and integrate, obviously, I think to me that's sort of the same thing as a frontalis flap, to be quite truthful. Anyway, thank you very much. These videos are available online. Happy to take any questions if there are any.
Thanks very much, Richard. Yes, there is some questions. And actually, thank you on behalf of the whole of Ocular Plastics for posting all those videos. I think an awful lot of us have been lost at times and have needed to avail of your talents and a few reminders. So just thank you on behalf of British Ocular Plastics.
Thank you. Thank you
It's
so
been
much.
very handy. We've got a question from Anya. Thank you very much for an excellent talk, Dr. Allen. Your video for the slings appeared to use the Visitech slings. They're currently not available in the UK, and
I
we
agree.
needed to resort to DCR tubes. Any alternatives have any?
FCI makes a sling. It's not as good as the Visitech. I agree. And so, again, that's, one of my, I think it's the FCI slings definitely are not as strong as Visitech, and especially I think you can get away with them with adults relatively easily, but I would, if I had a kid with severe congenital ptosis, I'd be unhappy with the Visitech.
Thank
I'm
you.
sorry, unhappy with the FCI, with the FCI.
Question from Xavier. Great talk. Any specific advice or tip that might help avoiding eyelash verticalization? I think you've mentioned the lid crease, but please, could you elaborate on that?
So with regards to eyelash ptosis,
Verticalization. So yeah, ptosis.
yeah. So, I mean, that's all lid crease. That's going to be vertical tension on the anterior lamella inferior to the lid crease. And so you need a strong lid crease. And, if after your surgery, I have had a few patients where they've come back and usually they do pretty well with time, but if I have anybody that at a month out, they still have significant lash ptosis, especially if there's any touch to the cornea, I'm going to take those patients back and I'm going to establish a lid crease. Usually I'm going to do that transconjunctivally, so sort of place what are similar to Pang sutures. I'm going to take a double-armed 5-0 vicryl, usually go pretty far up in almost into the fornix, and then that's going to come out. That's going to be past full thickness through the eyelid, each arm, just inferior to the existing lid crease to try to get that vertical pull to the anterior lamella. And I place like 5 of those sutures.
Thank you. Thanks, Richard. This is probably a lecture on its own, but what precautions would you use for patients with double elevator palsy, Marcus gun jaw winking?
Yeah, I mean, these are tough patients, and to me, a lot of it is lubrication. And for Marcus Gunn, there's like I said, we could talk about this forever. I talk it over with the parents, and I sort of ask them how distracting is the wink. I mean, realistically, you see adults, and a lot of people with time learn how to control their wink. I know Bill Katowitz, that CHOP, Children's Hospital in Philadelphia, says ignore the wink, don't worry about it. I will extirpate though. I mean, I extirpate. If it's a big wink and it's distracting, I think I extirpate. With regards to double elevator palsy, we're stuck. I mean, you're going to be a little more conservative. It's especially difficult, when it's unilateral, which it almost always is. And so, you have a discussion with the parents. I have a discussion with the parents, and I will place a temporary lateral tarsorrhaphy. So, this is actually something that we should discuss. You can put a frost suture in these patients at the end of surgery. Some people do that. I usually will place a temporary suture, lateral tarsorrhaphy that usually falls away. We use a gut suture. I know you don't have availability of that, but I think you could use probably a 6.0 Vicryl Rapide, and that would probably do the trick, at least for a week, just so that it's really that early time after the surgery. And if you get behind in with regards to the dryness, it's really hard to catch up. And so I've had a few patients where they've been dry and I just cannot catch up. And so I'll put a frost on them. I'll have taken to the operating room, put a frost in, leave that in for a week. And then, hopefully that catches up with regards to their dryness, and then, really read the riot act with regards to getting the parents to, give lubrication. Adult patients, just sort of on an aside, CPEO to me is really hard to treat because you have patients that can't move their eyes, can't open their eyes, can't close their eyes. And I love scleral lenses for them now. It's difficult to do that on a child, but, I use a lot of scleral lenses now in my patients with CPEO. And before I had that, I'd be pushing the lower lid up or, lowering the upper lid to try to get them. But a scleral lens works great in adults.
Thank you. Yeah, we had a few mad cows in the 90s, and gut is no more in the UK. So, in a similar vein, blepharophimosis. What's your choice in that regard?
So I like a lower lid skin redraping. So that's an incision that sort of extends from the medial canthus along the lower eyelid. I don't do anything with the upper eyelid. Medial canthal plication and then redraping of the skin. I like that a lot now for my medial canthus. I do that at the same time as frontalis flap I don't stage that procedure anymore. I used to. I used to do the ptosis and then I'd do the medial canthus later, but now I don't. I think the one thing you need to be careful is, those kids, there are reports of blepharophimosis, kids with no lacrimal glands. You have to be really careful. And I think that we probably have that a little more in bilateral congenital ptosis than we think. We don't scan these kids, which is sort of interesting. I'm not saying that we should, but, I think I've had some of my worst dryness has been in bilateral cases. And I always wonder, okay, did I miss lacrimal gland agenesis here? But there is a case report, I think it was Ana Duarte and Augusto Cruz talking about lacrimal gland agenesis in BPES patients.
Brilliant, thank you. Time for a couple more questions. We've got a great question from our very own Srigor. Thank you, Richard. Brilliant talk. How do you deal with the peaking of the contour or temporal droop following frontalis flap?
I mean, I look really carefully. I usually place 2 sutures, which I've had a few patients lately with more temporal droop than I want. Now I'm thinking maybe I should be placing 3 sutures, but I always place 2 sutures, don't place 1 suture. I always look at that contour very closely at the time of the surgery. I mean, contour abnormalities are difficult to fix postoperatively, conservatively, unfortunately. I mean, if you have a peak, you can try a little bit of if the child's old enough and they tolerate it, I have them hold the eyelashes, pull down in the area of the peak, have them look up and, trying to soften that peak. And so that's what I'll do if it's a peak issue and maybe they're a little high, I will try that massage. Sometimes that can be very difficult in younger kids, so they don't tolerate that well. I think a strong lid crease is very helpful with regards to softening out the contour as well. And so that's why I'm such a advocate for, a strong lid crease in these guys. I could never have too strong of a lid crease at the end of the surgery. I mean, I'm sorry, I couldn't.
Yeah, that's brilliant. I feel like we're abusing you, but there is a rich vein of questioning here.
No problem.
Why do you use silicone sling instead of fascia lata in OPMD patients?
It's just, I mean, it's a good point. If you could get away with anybody, you could get away with fascia in OPMD patients just because their orbicularis is still good and their Bell's phenomenon is still good. They have a good ocular motility. I think, it's very rare for me to harvest fascia in adults. And I think probably it's just my convenience more than anything else, in the sense that I can take this synthetic sling off the shelf. But I think it's also adjustability of the sling, and then also elasticity of the sling to prevent any dryness. You know, when I was doing this, I was actually doing it in the state of New Mexico, and this is high desert in the United States, and so it's not a great place if you get yourself into trouble with dryness.
Fairly arid. Just a few sort of technical queries with respect to the actual handling of the frontalis flap itself. So, do you advance it preceptally or postseptally, and actually, how far into the frontalis muscle do you go into? How
Yeah.
far up?
So
Do you do relieving incisions?
So these are good questions. So, you know, when I mark for the flap, I always mark the supraorbital notch if I can feel it, just make sure that I know my medial extent. I don't want to go over there. And then usually I'm extending it. Basically, you know, the width of that flap is going to be basically limbus to limbus. And then my dissection up, I usually mark about 1.5 to 2 centimeters, and that's going to give me enough, more than enough. Okay. I don't make any vertical incisions in the flap to sort of free it up. I think that puts you at risk with regards to potentially denervating the muscle laterally, just because you're getting your motor innervation laterally from the frontal branch of the facial nerve. So I don't make any vertical cuts. I don't think you need to. And then that flap just sort of comes down almost like a hammock, in the sense that, you know, it's sort of a curve to it. And, you know, I have opened the septum. And so by definition, that's not going to be preseptal. That's going to be postseptal. And then, you know, with incorporation of the levator, it gives me that posterior pull.
Yeah, brilliant. Thank you very much. I think we'll probably draw a line under the questions there, and a virtual massive applause. Thank you very much for the talk.
Yeah,
No, thanks so much for inviting me. It's
much.
wonderful to be here.
Yeah, thank you so much for coming, Richard. And that posterior vector that you've referred to many times, I think your demonstration was fantastic. I mean, you're obviously very well known for your amazing surgical videos. So it's really nice to see how you achieved that retroseptal placement of the sling as well. And because in the original description from Anderson, the right needle came from the other direction.
Yeah.
And so the description was as you approach the superior orbital rim that you then turn the right needle backwards, which obviously led to fewer uptake of that technique. So your adaptation is absolutely beautiful, and thanks for sharing all those photos showing absolutely incredible skin creases that you've achieved on so many of those children. So thank you. And our next speaker is Tristan McMullen. Thank you, Tristan, for joining us from Northampton. Tristan has a lot of experience using the mullerectomy in congenital ptosis in the correct selection of patients, and is well published on congenital ptosis. So thank you so much, Tristan, for joining us.
Thank you so much to you, Aoife, and Colin and bopss for this evening. I really enjoyed the first tranche in January and learnt a lot, and I've already changed my practice actually. And so I think this is a fantastic idea. Thank you to the previous speakers, and it's quite hard footsteps to follow, but I'll do my best. So I'm just going to talk about Putterman procedure in children. Why would you want to do that when you've got all these other options? Why would you not want to do that? And how to do it, which I'll actually demonstrate on an adult patient. So why would you bother doing a Muller's MMCR Putterman procedure in general? And I put the E in there because I missed a few papers actually when I was doing some research looking at this because of the different spellings and different sides of the Atlantic. And so I just commend that if you're going to look these things up, look it up both ways. Well, the main sort of thing is it's very quick and easy, sort of 10-15 minutes. It's simple for a simple person like myself. It's extremely predictable, which I think is why I like it most. The contour is wonderful. You don't have these weird sort of funny shaped lids afterwards that whilst the MRD might look fine, the actual lid looks terrible and the lid shows off. You can do it under local or general, and obviously in general anesthetic for cosmetic cases and things, it's great because you don't need any patient cooperation. And patients are very satisfied, and that's, I really think, what we're aiming for. So Alan Putterman described this in 1975. I always think it's slightly ironic, given that the published picture has a bit of a ptosis. I'm going to take the same approach as Professor Allen. Just, we're assuming we're going for surgery, but we've got to examine the whole patient. You've got to exclude myopathies and neurology and make sure you're choosing the right thing for the right patient. But I'm just going to dwell on the procedure, and obviously they've got to be suitable for surgery. So my journey into this really started sort of using the phenylephrine test, which I would commend to everybody if they don't use it already. It's a stimulant, obviously, an alpha agonist, and it stimulates Muller's muscle. And I started using it really to unmask contralateral ptosis. Once you lift one lid, the other one might drop, and you need to warn patients or parents of that eventuality that you might end up doing the other eye or do both at the same time. I used to, particularly in cosmetic patients, I like to show them the likely outcome that we can achieve. And if they're not bothered and can't even see it, then I think you're probably wasting your time. So I think it's helpful in that regard. I've switched to using aproclonidine because it doesn't affect driving, because obviously it doesn't dilate the pupil. And I think aproclonidine is better in other ways as well, because we're all very good at, or at least I think we are, measuring MRD1, but there's a lot more to it than that. There's the lid show, and also when you look at the lid margin, I think often the patients and perhaps ourselves subconsciously are seeing the lid position compared to the pupil margin, not the light margin, not the light reflex. So I think if you alter that with your phenylephrine, then you're kind of confusing yourself as to where the lid's sitting mentally, if not physically. So aproclonidine's a suitable alternative. It's been in the literature a long time in OPRS. And is it safe in children? Well, yes, it is. So get on with it. That's fine. Here's a very developed child with a phenylephrine test, and you can see you get a good lift, even in quite severe ptosis. I tend to get the patients to hold up the dose. That's a minim for people who aren't familiar with them, just to sort of see a sort of pre and post test. And that's an OPMD patient Richard was talking about. I've got a research interest in that as well, not as extensive by any means. And here's another patient with myotonic dystrophy, so another myopathic ptosis. And indeed, here she is after a Putterman procedure. So it got me thinking that, you can use the Putterman outside the box, so to speak. You can use it in myopathic patients with caution, because you're not messing with the orbicularis and affecting their closure and lagophthalmus. And I started to think about using it in children and have been. So why would you want to use a Putterman? Well, you can reliably correct at least 2, possibly 3 millimeters of ptosis. There are some relative contraindications, glaucoma filtering surgery, although there are papers to say it's fine in that. That's not really relevant in most children. Ocular surface disease, well, that's true of any ptosis surgery, and perhaps less so if you're not messing with the orbicularis and affecting the closure. And as I think it was Professor Allen said, every time you go through the orbic, you are reducing its power and function, and you can't do that indefinitely without expecting problems. It's easy under local or general, and I've restricted my practice to phenylephrine or iopidine test positive patients. There's plenty of evidence out there that it works in other patients, but it may be less predictable, and it's the predictability I like, and maybe I should widen my scope. But that's what I do. So how does it work? Well, I don't think anybody really knows. I think it's a white line advancement, which is obviously popular at the moment. It's unclear. There have been histological and functional studies, but I think really you're pulling the white line down. And just to be absolutely clear for people that aren't very familiar with the procedure, it's not, as in not a Fasanella servat. So the tarsus is unmolested in any major way, and you're certainly not shortening it. Although there are people that do both at the same time, I do not. So just to in contradistinction to what I would call a Mullerectomy is when you excise Muller's to drop a lid in thyroidectomy in a thyroid eye patient, then that's a sort of separate operation with a different effect. It's a lid lowering. So there are lots of different formulae out there. Mine was one I was trained with. I used a 6mm resection to gain 1 millimeter and a 10mm resection to gain 2 millimeters. And that's my go-to. I will be pushed into 12 millimeters to get 2.5 or thereabouts. But there are some people that do the same resection for all cases, and there's quite a lot of interesting debate about that. I've sort of just stuck with what I was taught, and it works for me. I'm sure other people could tell you different things work for them. In my standard practice, I'll get a pull-out stitch that comes out at 5 days. I don't know if you can see the cursor, but there's a very long tag there. I wouldn't leave it that long. Not much bruising at 5 days. And out it comes. And I just put this picture in just to show that even though you're doing a posterior approach ptosis, it does affect the lid crease, or at least the lid crease and tarsal show. So I think, people might be concerned that if you're not going through the front, you're not going to affect things properly at the front. Well, you can affect the front because I think it is a white line advancement. So you're getting a better symmetry in the lid show, which is obviously what the patients actually see. Obviously, surgery carries complication risk. I've caused one rather nasty corneal abrasion that ended up getting recurrent erosion syndrome, which wasn't much fun for patient or indeed surgeon. I've had a couple of cases or 3 cases that have dropped later. So they seemed all right. And then sort of, I don't know what happened. The tissue's probably stretched apart. And then I've revised these via an anterior approach. I've had one horrible case of a symblepharon, which I'll show you in a moment. And that's something to be careful about. And I've had a couple of cases where the suture was cut peroperatively, i.e. when you're doing that pull-out stitch, you cut it when you're removing the tissue, which actually isn't as big of a deal as you might think. You just oversew it. And in fact, the one case that I had, the other was a fellow, it gave a better lift than I was expecting. So there might be some mileage in that as a technique. So here was this symblepharon, which was pretty unpleasant for me and for the patient. It didn't cause any double vision. It just meant the lid didn't lift. I think what happened is that the raw edges of the palpebral conjunctiva stuck to some raw bits of bulbar conj, and the raw bulbar conj, I think, was produced by the suture being too tight. So I think the proline, what it was, 6-0 proline suture, was like a string on a bow and started scraping against the bulbar conj, generating some epithelial defects. And then one bit of sticky epithelium stuck to another sticky epithelium and therefore caused the symblepharon, which didn't read revision, thankfully, but was a bit of a shock. I'm very awake to that. And I think it was the suture was too tight. I don't know that, but I assume it was. So why would you do the posterior approach? Well, the contour's brilliant. There's no scar, obviously, unless you get a symblepharon. There's much less swelling in my hands. There's no fornix prolapse, and nobody's mentioned this so far. Maybe it's just me, but certainly with supramaximal external levator resections, anterior approach levator resections, then I have had a couple of cases now of fornix prolapse, which it's not the end of the world, but it's not ideal. I was just wondering, as Richard was talking about when he was going up as high as he can behind the levator during the frontalis flap, whether or not that ever became an issue, because it certainly has for me. I think cutting the horns, etc., it can be a problem. Anyway, you don't get that, so you don't have to worry about it. And it doesn't really compromise any of the anterior structures, so the septum and orbicularis and all that sort of thing are all fine. So if you want to go back in, you can. And conversely, if you want to go in after an anterior approach, you can go through the back. So that's a sort of plan A, plan B type thing. It's also very quick and easy. So what about in children? Well, in the Cold War era, as we've been hearing, you either had a brow suspension or anterior levator resection, depending on your levator function. You choose your number and you go one way or the other. In the modern era, we've obviously got frontalis flap, which we've heard about so nicely. and the white line advancement, which I'm sure Raman is going to describe beautifully next. And there are lots of variations on a theme. So I noticed really lovely lifts with proclonidine in kids, and I thought, well, what can we do? Can we do that with ptosis? In fact, it's been done for quite a long time, and I just missed all this because I spelt it my way. This was 2011, a series of 8 patients. I think that was Texas. And so it's been used in the States for some time. So why wouldn't you, I guess, is the question. What formula do you use in children? It's a good question I haven't got an answer to. I use the adult formula. We don't really know the relevant heights of the tarsus and the fornix depth, so you can't sort of take a conjunctiva away at your leisure because you've got to leave some. Otherwise, you're going to shorten the fornix, and you're obviously sacrificing goblet cells, etc. Removal of a suture in children could be possible deterrent. As has already been mentioned, we don't have access to gut, which would be the obvious thing to do. And as I've touched on, there's the idea of conjunctival sacrifice. Is that something you want to entertain in a child who's got, 70, 80 years of life ahead of them? So it's quite easy, the data on fornix depths in children, there isn't any. So if there are any squint surgeons who do lots of squint surgery and want to measure fornix depths and publish a paper, that would be a quick, easy win. There's a tarsal height study, basically it goes from about 7 to 8 millimeters over the sort of 0 to 13-year period. So it changes about 1 millimeter, so I'm not really that worried about it. So I think the adult formula probably pertains. So in my practice, if there's an acceptable lift with arpidine, then I'll do MMCR just regardless of the levator function. The rationale being, if I can lift it with the arpidine, I can lift it with the putamen. It is true that the patients with poorer levator function have more than a 2 millimeter ptosis probably. And in those patients, you're going to struggle to lift it. But sometimes lifting it by 2 millimeters and giving them a 1 millimeter disparity rather than a 3 millimeter disparity isn't the end of the world. You can always go back and do more later when they're older. The removal of the suture is an issue, and I'll come back to that in a minute. I tend to place a bandage contact lens, which would also need removal. And of course, there are children who are too young or too uncooperative to take the stitch out, and you might have to give them further anesthesia. I have had one patient that needed to go back to, well, not to theatre, just literally an anaesthetic room for a sniff of gas to take the stitch and the contact lens out. And that's very patient dependent or parent dependent. So there's always jeopardy, as there is when you're doing anything like the Cresta run. But is a suture really desirable? This is a lovely paper which I hadn't seen until I started preparing for this talk. And this group basically don't bother with a suture at all. So that takes that out of the equation. And so they use a monopolar cautery to create a sort of join between the 2 cut edges. So I think the suture thing probably is a bit of a red herring now, and we could probably move away from using one. I haven't yet done this myself in an adult or a child, but I think that's probably the direction of travel. Thinking about revision rates in this series of 2,000 odd patients from the Korea, 1,800 had congenital ptosis, and their revision rate was about 15% for that. And Antonella's paper, the revision rate was about 20%. And this is Guy Ben Simon's group, and they had 30 patients. Sorry, I'll just tell you, it's reoperation rates for congenital ptosis, the different techniques. And in Guy's paper, 18 patients had MMCR. So that shows that in about a third of his group, he was using a putamen procedure, which shows you that it's fairly prevalent. His failure rates were up to a third with the frontalis These were slings, not flaps. A levator resection, about a quarter, and much the same with an MMCR. And interestingly, the readers, they went back straight to epitomen, which means they obviously believe in the technique. So in conclusion, I think it works in children. Well, I know it works in children. I think the removal of the suture and the bandage contact lens may be a bar that is not really there anymore. It's minimally invasive. Revision rate is comparable. I've not had to revise any. Of course, might have to tomorrow. It's not likely to compromise revision. It's quick. There was a study published recently with a unsutured technique taking 4.42 minutes, which is fairly precise, and versus a sutured technique taking 8.45 minutes. So let's call it 5 versus 10 minutes. So you're going to get in and out fairly quickly, which is a good thing all round. I like it because it's easy and it's stress-free, and I like to look after my myocardium. So if we've got time, let me just see where we are. Yeah, we have got time. I'll just run you through the techniques. So this is a patient for surgery. You can see he's got quite a lot of ptosis. You can see he's also got alopecia. You can also see that he's had direct brow lifts. So here's the traction suture going in. You've got, I use a 4O silk going through the upper lid. Obviously, he's had some anesthetic, which is why he's got a bruise. You then infiltrate underneath the conge in the same way as you would for any posterior approach type thing, and balloon it up. This is obviously looking from below. I then use a hot tip cautery to mark out where I'm going to grasp the conjunctiva. Use a caliper to measure it. So for a 10mm resection, just to be clear, I would be measuring, 5mm. So when you do your double resection, it's 10. So you don't measure 10 because you'd end up with 20, which would be too much. So just to be clear, if you want 10mm, you measure 5. If you want 6mm, you measure 3. So here are the little burn marks, which I've shown you there. And then the next couple of pictures aren't fantastic, but you grasp the conjunctiva. This is where you need another hand, an assistant. There are techniques where you can use sutures through the conjunctiva. And then you place the clamp, and that's better illustrated here. And then there it is. Dog's going crazy. And then, so the clamp is placed, the traction suture is still there. I would remove that these days before messing around with the next stitch. And you pass the stitch, I enter laterally. I don't know if you can see my cursor, but let's go through the skin, you go underneath the conjunctiva up to the region of the clamp, and you go backwards and forth underneath the clamp, and then come out again underneath the conjunctiva in what I would call the medial fornix, out through the skin, and then you go back the way you came. So back in, through here, backwards and forwards. So here's the needle going in. That's a slightly too magnified picture of the needle coming out. You're going to want to get it as close as you can to the clamp. And then you go backwards and forwards, you go away and then come back and away and back in a serpentine fashion. And then this is now looking from below. So you've gone in laterally, you've come along and you're going out through the skin, and then you make a loop and you come back in. This is entering too far away from the clamp, and that's actually not very good either. But the idea is to get the subconjunctival suture up to here, and then you go back the way you came to end up with that. And this gives you the opportunity to have an externalized pull-out stitch. This is 6O proline. So the loop, the long end goes through the loop that you've created. So the loop, you take one of these ends and push it through that loop like that. And then you pull it tight, but not too tight, as I've mentioned earlier. Cut that. So this becomes a loop with a knot that you fashion from these ends. And then you suture these ends here to create a pull-out suture. I just can't advance now. What's going on? So you've created a pull-out stitch, and then you cut the conjunctiva with a 15 blade, cutting upwards onto the metal on metal, because what you don't want to do is start catching the proline here, because you'll cut your pull-out stitch, and then it obviously won't approximate the edges. So you go along the clamp, keeping it close and up onto the clamp as you can. And then that's the sort of appearance. You get a little bit of chemosis there, well, quite a lot of chemosis. And then the lid shuts. And then I place a bandage contact lens as discussed earlier. So here are your two pull-out stitches, one lateral, one medial. I tend to, when I remove it, I pull this out, cut there, and pull that out at 5 days or up to a week, to be honest. So here he is post-op. So it's pretty good, pretty symmetrical, and a favorable result. And that's the sort of thing you can get in children as well. Obviously, they're asleep for this kind of thing. And I would commend it as a technique if you're trying to achieve 2 or 3 millimeter correction that you've demonstrated with iopidine. I haven't used it on phenylephrine or iopidine negative patients, and I wouldn't suggest you do. But if you can reliably, or at least you can demonstrate a nice lift in the clinic, in the outpatient department, and you can satisfy the parents, that's what you're going to give them, then all things being equal, you probably will deliver on that. And you might sort of say, well, hang on, why would you want to be doing ptosis surgery on these small amounts of ptosis? And I would counter that and say, well, these are the ones that are much, much harder to do by any other technique with an asleep patient. So if you've got a small or microptosis, and you're going to put the child to sleep, obviously, to operate, you've got no intraoperative control over the lid height, really. You've got to guess it. And guessing it to be within a millimeter when you're starting with a millimeter is a tough job. But with this, you're pretty safe at getting what you want. And so that's why I've sort of used this when I can. It's not a substitute in patients that don't have a phenylephrine positive result. It's not a substitute for patients with poor levator function and who are going to need a brow suspension or a frontalis flap. But I just started using it really in that select group of patients, and I think it just you can give in theatre in the OR what you can give in the clinic, and then you can predict what you're going to get. And even if it only lifts by 2 millimeters instead of the desired 3, maybe they'll take that on the chin as long as it's all agreed. And so I really think it's got a place, and I would encourage people to think about using it. So post-operatively, Maxitrol 3 times a day for 5 days, and take out the bandage contact lens. I don't bother with unpreserved drops for a short period of time. And I think it's just great. You can go off, get in your hammock and relax. Whereas I think with a anterior levator resection, it's not a relaxing thing at all. You don't know where it's going to end up. They're going to get worse lagophthalmos, they're going to get hang up and down gaze, and it's much more stressful. So if you can avoid all that, keep your myocardium perfused and healthy, enjoy your hammock, and thank you very much.
Hey, thank you very much, Tristan, for a very nice description of an efficient and predictable technique. So how do you plan your degree of resection?
So if I want to get 1 millimeter, I mean, to be honest, in children that's not necessarily relevant. I would do a 6 millimeter resection, and if I want to get 2, I would do 12. Sorry, I would do a 10 millimeter resection. In adults, I'd be pushed to doing a 12 millimeter resection, but I have yet to do that in children. I think once you get into that level, I sort of start to back off. I'm a bit of a coward. I don't want to cause trouble. I can reliably deliver with those 2 numbers. If I want a millimeter, I'll do 6. If I want a millimeter and a half, I'll do 8. You really can titrate it that well. And if I want 2 millimeters, I'll do 10 millimeter resection.
So you're predominantly titrating it against the MRD1?
Yeah. So if there's asymmetry of 2 millimeters, so the ideal patient would be, MRD5 on one side, and an MRD3 on the other. You go in there, you've got 5 and 5, everyone's happy.
Okay. And then in response to your iopidine test, so if you get a partial response, are you then inclined to go for a little bit more resection?
I mean, there would be a good argument for doing that. I don't. I think one of the things with the iopidine test is, sometimes you sort of do the test, you think, oh, it hasn't worked very well, and you sort of carry on the consultation, and you look back at the patient or the child, and actually it's worked pretty well. Sometimes I think it just takes a bit longer. And so I would just give it a chance to work, but I wouldn't fudge it. If it doesn't work, I wouldn't try and make it work. So if it gives
Right.
you the result, I would not promise, obviously, but I would be confident of delivering the result.
So on that theme, Anya's asked a question: if the phenylephrine, if it's negative to the phenylephrine test, what technique do you prefer to use, Tristan?
Well, that's a very good question. I mean, if there's poor levator function, I currently do frontalis slings. I'm very keen to try the flap. If it's a good levator function, I would tend to do an anterior approach to ptosis, so an levator resection. I think now I'm toying with the idea of an anterior white line advancement. I haven't done posterior white line advancement in children. Raman's going to talk about that very shortly. I just haven't, so I'm not saying it doesn't work, but that's what I do. And so with children, I would try and do fascia lata, if appropriate. We still have a fasciotome, although I will look up that Mohsen Kashkuli's paper about doing without the fasciotome, because you can't buy them anymore. So, well, you can, but they're not CE marked.
Okay. There's a question here from Vladimir Kratian. What role does the levator excursion play in choosing this technique? I know you mentioned there's likely more of a white line advancement by proxy as to the mechanism of its effectiveness.
I mean, the truth is, it's sort of irrelevant what the levator function is if you can get it to lift with the iopidine, but a sort of corollary to that is it's unlikely to lift in a very poor ptosis with a poor levator function.
Okay. And a question from Shrigvor: are these older children predominantly, or are you using it for all ages?
So, I mean, I'm using it for all ages, but for children as well, it's really. Sorry, what was it? Just to the question?
In terms of do you have an age range or limit where you'll offer it if more likely they are to have more?
I mean, obviously, there's the anesthetic
you might
issues in
need-
infants, but any child that I deem would benefit from, iopidine positive, I would crack on and do it unless there was a contraindication.
And so because a lot of your will be those patients with a mild ptosis who are looking for maybe 2 millimeters. Have you got a tendency towards doing it in the preschool age to kind of predominantly
do
if it's
whenever they present, and
okay.
so if they present and they've got a ptosis I can fix, I'll try and fix it, regardless of age, within anesthetic limits. When I haven't done it on newborns and 2-year-olds.
Okay. Can it be repeated? There's a question here. And after, if yes, what's the time period?
I've not had to. I've not had to revise any, but that paper by Guy Ben Simon, he had 5 out of 18, I think it was, patients that needed revision, and his revision was he did another Putterman in 4 out of those, in 80% of them, and the other one he did an anterior approach. So the answer is yes, it can be repeated. I haven't, and I have to say probably wouldn't myself, but it can be.
Okay. Do you think the age at the time of surgery is in any way related to the success?
It's a very interesting question, that, because I did the first patient I did on, it was I think he was about 9 at the time, and I've seen him more recently as a young adult. And actually, he came back, and it was apparent that, going back to perhaps Richard's point about looking at levator health rather than levator functioning, he actually has come back sort of whatever he is now, 14 years later, with a myopathy. So you know, worked for him for 14 years, and then I've recently done I can't remember exactly what I did do. I think I must have done slings. Yeah, I did slings for him, silicone slings, because of his myopathy. But I mean, my experience is limited, but I haven't seen people back with what you might call a late failure unless there's another disease process has supervened.
There is a very good question here on how do you adjust resection length in asymmetrical cases. So you showed a lovely example of where you achieved incredible symmetry with quite a marked asymmetry in the preoperative ptosis.
So the one side would have had probably a 6 millimeter resection, and the other side would have had a 10 or possibly a 12 in that case. So you tailor the resection to the lid rather than to the patient.
So you're tailoring it basically as to the degree of lift that you're aiming for on each
Yeah.
side. Okay.
And that's why I think it's so nice, because it's so predictable. If you want to lift it if you want to lift it 2 millimeters, you pretty much can, and you don't really have to worry about it. And it's quick and easy. Whereas, you know, once you get into 1 or 2 millimeter ptosis, if you were to go through the front, you know, it's getting a little bit sweaty. You know, you might end up doing an operation and they might end up no better, or you might overcorrect them. Whereas this, you say, well, I'll give you a millimeter lift, off you go. We're happy.
And if Richard Allen is still there, actually, you mentioned the point about assessment intraoperatively of the appearance of levator. Richard, have you noticed a difference intraoperatively that is age-related, per se? And it might be a difficult question to answer, but there were some reports in the literature that kind of increased fibrous change and fatty infiltration seems to be correlating with increasing age in patients.
Right. I have not, I haven't paid attention to it, maybe I should say. So, you know, to me, you know, like I said, a lot of it to me is when I'm trying to determine the health of the levator, or, you know, throwing that into my calculation with regards to whether I can do a frontalis suspension in the patient or a levator resection. You know, I look at the levator, and if I see healthy muscle, I will use it. Now, am I worried about, you know, progressive? I mean, to me, I think congenital ptosis is a static process. It's not a progressive process. And so I understand those studies, but I mean, realistically, you know, is it going to affect my surgery? I don't think so.
Very good. So we're kind of running over time. Even though so we must move on to our next talk from Raman Malhotra. Thank you so much, Tristan, for a lovely demonstration of that technique. Raman unfortunately can't join us this evening, but he's very kindly provided a pre-recorded lecture, which will now play on his preferred technique of levator pexy, showing really remarkably effective results even in, you know, the most severe cases with poor levator function. So we'll just play that video now.
So it's a great honor to be involved in this meeting. I'm really sorry that I'm not going to be actually present. It's just that I'm skiing in Norway at this time. But basically, I'm going to cover 4 aspects. So I'm going to touch on some aspects which I think have really helped me in the assessment. I'm going to raise some issues in terms of how we should be thinking about defining congenital ptosis and anatomy. And then finally, I'll talk about the posterior approach levator pexy. So in terms of the assessment, this is a really important paper that was published in 91, which highlighted that even in bilateral ptosis, you could get bilateral amblyopia, and particularly in ptosis that wasn't necessarily affecting the visual axis, so one of those partial ptosis that perhaps didn't warrant surgery at the time. And the main reason we now understand is that the partial ptosis, not the complete ptosis, partial ptosis can actually also be amblyogenic. It can affect that mid-peripheral vision or the parafoveal area of the retina that can contribute to amblyopia. So actually vision assessment and doing surgery at a lower threshold where there's any suggestion of vision not being quite right is now considered more appropriate than only operating on that which affects the visual axis. So again, MRD2 as a ptosis, you would be as equally concerned about amblyopia as you would for the MRD naught ptosis. Second issue in terms of assessment is using the phenylephrine test. So you know putting phenylephrine in the right eye is useful as it elicits Herring's law, so it helps reinforce bilateral surgery. If you were doing Conge-Muller or Muller resection, then a phenylephrine test would help your algorithm in terms of how much Conge-Muller to resect. But even for levator-pexy, the child, the left picture is the congenital ptosis, right congenital ptosis. The middle picture is following a phenylephrine test, so she's partially positive. And then the right picture is following a levator-pexy. And I will cover how I use the levator, the phenylephrine test to help my decision-making in planning surgery. So again, another example where the Herring's law is useful. So the picture on the left shows someone with more of a left congenital ptosis, but the middle picture after a phenylephrine test, you can see that the Herring's law has accentuated her right, what I would have considered a latent congenital ptosis. So therefore, the picture on the right is 2 weeks after a bilateral levator-pexy procedure. Had we only done the left eye, then she would have been bothered by her right ptosis after surgery. Okay, defining success. So if you look at all the published literature, the criteria to define success is included in any one of these criteria. In general, the middle one in red is a typical criteria for success that is used. That's an MRD of between 2 and 4.5 into height asymmetry of within a millimeter. But the problem with this and congenital ptosis is it just relies on a single appearance in primary position. And if you think of all the consequences of congenital ptosis, it ignores then the consequences of lid lag in down gaze, nocturnal lagophthalmos, dry eyes. And I think the lid lag in down gaze is a particularly important one to now consider, not only in planning your surgery, but particularly for consent. Back in the day when I was training, lid lag in down gaze was something I would consider, say, if I was studying in the library, looking down at my book, or in an office. But with smartphones, and you sit on any train and everyone is looking down, the issue of lid lag and down gaze now is how you appear to others in public. And given that for young people, that can often be one of the reasons why they're having congenital ptosis surgery if they're a bit older. And if they're having it as a child, well, they may not appreciate it, but it will become an issue as they become teenagers and older. Once they realize how they look, when they're looking down and their lid lag and down gaze is accentuated, you are going to create an issue for patients if you didn't counsel them on that. So in that regard, using the phenylephrine test is a very useful test prior to surgery to show them, if they are phenylephrine positive, show them how it will look in down gaze, but just highlight that, because if the patient suddenly becomes aware of their lid lag in down gaze, they're going to feel that, and if they're not expecting it, they're going to feel very upset, and it will just feed into whatever issues they may have about their appearance and the ptosis being obviously that big driving issue. So you'll swap one problem with another. So in terms of consent with Montgomery and the other issues of consent, the consent has to be relevant to the patient. So for congenital ptosis, that consent has to be relevant to them using smartphones and the issues surrounding that. Okay, so the second thing is then, or the third thing, is the issue of pretarsal show. So tarsal platform here and the subbrow fat span or preseptal eyelid, which is more important? It has been argued that ptosis surgery, just as blepharoplasty surgery, is an exercise in achieving symmetry of pretarsal show, regardless of MRD. Now, you may think, well, that doesn't make sense. We've been talking about getting symmetry of MRD. But I would argue that symmetry of pretarsal show is probably more important. And if you take this example and you reduce your subbrow fat span, that doesn't really look any different because the pretarsal show is symmetrical. And most of us have asymmetry of our brow heights. But if we have asymmetry of pretarsal show, that is what is going to drive someone to want eyelid surgery. So if you then reduce your pretarsal show here, and you have pretarsal show asymmetry, if you look back, use soft eyes, you will get an impression that this patient may actually have a ptosis on their right side, which they're compensating for with some brow compensation, when actually the MRD hasn't changed. So I would argue that for congenital ptosis, it's important to aim for a low pretarsal show. With that, it will allow you to undercorrect your ptosis and reduce the impact of lid lag in down gaze, reduce the impact of nocturnal lag ophthalmos, yet you will still achieve a nice aesthetic result. And I'll give you some examples. So left congenital ptosis after surgery, so slightly undercorrected, but because there's a reduced pretarsal show, it won't look so noticeable. Another example, right congenital ptosis, the ptosis is undercorrected, but again, because the pretarsal show is less on that side, aesthetically, it will not look so bothersome. And as you know, if you're used to a congenital ptosis, you do not want to get exact or higher an overcorrection, because that can look particularly odd. So you really want to be undercorrecting your congenital ptosis anyway, because that's what's going to feel natural for the patient. And the third example, right congenital ptosis, perhaps not undercorrected, but again, I would put it to you that you could undercorrect that and it would still look natural because the pretarsal show on the right is less. Okay, quick comment on anatomy. So Hirohiko Kakizaki described that the aponeurosis, levator aponeurosis, has two layers. The posterior layer is a smooth muscle layer. And basically, he made the point that the anterior aponeurotic layer is that which becomes continuous with the septum. So that's the continuous layer, and it's that layer which also helps form your skin crease and the skin fold, or you're getting from pulling of levator. So the bottom line is that if you want to get a successful lift, then you need to concentrate on also including the posterior layer of the aponeurosis. And then the second issue of anatomy that I want to highlight is the post-aponeurotic fat pad. I published this 10 years ago now, and these were cadaveric drawings. And basically, this is a diffuse sheet that you'll find lying on the surface of Muller's muscle, and it is present in everyone, adult and child alike. So these are examples of cadaveric dissections, conjugal flap, and there's a flat diffuse sheet. You'll see it more medially rather than laterally, and it looks infiltrative, but it is basically a diffuse sheet. And I think this is what people used to describe as a sort of fatty mullers. What they really were looking at was the post-aponeurotic fat pad. And I say that because if you look histologically, it is a distinct layer between Muller's muscle and the posterior layer of the aponeurosis, the smooth muscle posterior layer. So these histological drawings basically show there's a distinct fatty layer between Muller's and the aponeurosis. Okay, so moving on now to posterior approach to levatopexy. So traditionally, the approach to managing congenital ptosis was based on the severity of ptosis and levator function. And you've already heard that for frontalis, surgery, suspension, and nowadays more and more now we're using flaps. For poor levator function, 4 millimeters or less, we tended to do a frontalis procedure, and greater than 4 millimeters than a levator, which usually involved a resection. And the degree of resection was dependent on the severity and also the levator function. Kroll-Beard's classification depended on levator function, on how much to resect or what you left the eyelid at during surgery. Less than 8 millimeters levator function, you would perhaps place the upper eyelid higher on the table, knowing that it's going to drop, and vice versa. More than 8, you would expect there may be a slight rise. The previous teaching was you wait till preschool because you get better measurements, but actually nowadays the consensus amongst most people who do congenital ptosis is that they wouldn't wait till the age of 5, do it younger and younger, and generally once it's safe from the point of view of a general anesthetic. So in our hospital, any time above the age of 1. For me, I would prefer around 2. But I don't have a cutoff of waiting for preschool, partly because of that amblyogenic visual deprivation, but also it's just not going to make a difference in terms of my measurements, what I'm going to actually do. So these are some of the advantages for early surgery, and this was actually something that was advocated even in the 60s, earlier surgery. So I would definitely urge you to consider that. But if you think about the posterior approach techniques, remember that Fasinella Servat was initially described as a case report for a congenital ptosis. They thought they were doing a quick and easy levator resection by clamping the tarsus and the conge and excising that. But we subsequently discovered years later that when they analyzed histologically what that excision was, no levator. And so we realized that that was just conge and Muller's and some tarsus. So hence Putterman developed the conge-Muller resection, just excising tarso-Muller's. And at the same time, in the mid-70s, Abraham Verb in the UK was describing the open sky Muller's resection, where he was doing a tarsectomy, but also then excising a conge-Muller's flap. And that was achieving the result by splinting levator forward. Richard Collin, who worked with Abraham Verb and then went to San Francisco and worked with Kroll-Beard, evolved that to basically do a levator resection or levator advancement, if he was doing an advancement with a tarsectomy, but by opening up the septum and converting it to the appearance of an anterior approach levator. The white line advancement, I published that about 2009, was basically just an advancement of the posterior surface of the aponeurosis, the key difference being no tarsectomy and no opening up of the septum. So this was a septal sparing procedure, and perhaps in older patients, a septal sparing procedure helps explain why the contour is so much more predictable, because you don't weaken the horns, medial horn particularly. So the height is quite easy to achieve, but you may have to adjust it, but the contour tends to be very, very predictable. And so the levator pexy is an extension of that white line advancement, where you're just going higher on the levator following that posterior surface. So this is from the first levator pexy paper, now about 11 years ago. And this diagram shows basically the suture that is placed higher up on the levator and then passed to the tarsus. So hence creating a pleat in levator. And so given the fact that you haven't actually cut levator, it's more of a pexy, hence I called it the levator pexy. So this photograph shows the conj Muller's flap. This is the reflected posterior surface of the aponeurosis. And I think with the eye of faith, you can see that there's a yellow surface here. That's the post-aponeurotic fat pad lying on top of Muller's. So if you wanted to do levator pexy, you would then dissect on that fat pad posterior to this apo. Remember, the fat pad ends at the junction of the aponeurosis and levator. So beyond that, you just follow the conjunctiva and you would stay behind the posterior surface of levator. So this is a video that's on YouTube, which shows a congenital ptosis levator function of 7 millimeters. So I pretty much do it similar as this video. This was recorded, I think, 2012. I nowadays would use a shield for all ptosis surgery. So you de-epithelialize the top 2 millimeters of the tarsus, make a conj Muller's flap with an incision just at the superior border of the tarsal plate. One thing I would do differently now is I would take the demar out now a lot sooner than I used to. So the demar would have come out now if this was me operating now. And you can see that posterior surface of the aponeurosis here. But once you take that demar retractor out, it's just so much easier. So you have your assistant still holding the conj flap, and now the demar is coming out here, but should have come out a while ago. And I'm going to, at this point, so this would, if you're doing a white line advancement or a simple aponeurotic repair, you'd probably place your sutures in a healthy area of aponeurosis. And generally, at the point of the peak of the tarsal plate, the height of the tarsal plate. So it's not really relevant to the pupil, but at the peak of the tarsal plate. But for a levator pexy, in this patient, levator function of 7, I'm going to go higher. I'm going to go about 4 or 5 millimeters above the junction where the aponeurosis becomes levator. So I call that a junction where the aponeurosis becomes levator, and I've exposed about 5 millimeters higher, and I use a double-armed vicryl suture. The suture, and really just capture the posterior surface of the muscle. I want to incarcerate your sternal fat, so and then pass that through the top of the tarsal and through the skin. Now, nowadays, that second needle, I will also capture the distal conj flap. So this one, I would pass it to the conj flap before then passing through the skin. So this is the kind of effect and result that you can expect doing a levator pexy, and it's very predictable. So my need for brow suspension surgery has plummeted since doing this.
Apologies. It looks like the video's crashed. Ben is going to work his magic and try and get that back online again. Once again, apologies for the quality of the video. We've just had some buffering issues in the UK. Give us a moment. I'm sure we'll get the video back online again.
I'm just conscious we've already run quite over time. So if anyone does need to go, the video will be available, and we will have upgraded it and removed the sound issues for the recording.
Brilliant. We'll probably draw a line under the meeting there. And there's no. Oh, we've got round the back. How long's left on the video? Not long. We'll run the rest of the video and then make our say our apologies and say.
Resection. But even for the levator function less than 7, the success was really high, and 90% was what we found. Nocturnal lag ophthalmos, really low rate, and we specifically asked parents. Our Lefferin test was fully corrective, then regardless of levator function, I would just place my stitch at the junction where the aponeurosis becomes levator. If the phenol test was negative or partially positive, then if the phenylephrine test was negative or partially positive, then if the levator function was more than 8, I would place my suture at about 2 to 3 millimeters. I'm going to show you. This was recording a video of him immediately after surgery.
Right, I've made a presidential decision to draw a line under the video there. As Aoife's quite rightly said a moment ago, the video will be available online as part of the final edit. Never work with children, animals, or videos by the old adage. So I'll open it back up to the group. We've had some vibrant Q&A throughout the meeting. It doesn't appear that there's any final questions for the panel. I would be inclined to just say thank you to everyone, especially Richard for joining us from the States, and wish Duke all the best in the rest of March Madness. We may well be seeing a few of you at Voice in Istanbul in a few weeks, not least Brighton later in the year. So thanks to everyone for your time tonight and your attention. Please feedback, and we hope to offer similar offerings in the future. So thanks to everyone for your time tonight. And thank you, Richard. Have a great day. All the best.
Thanks.